Welcome to the CME accredited podcast series, Rethinking PC-IOLs, from evidence to clinical decisions. I'm your host, Dr. Jennifer Loh, a cataract refractive surgeon in Miami, Florida, and I'll be in conversation with leading clinical experts exploring the presbyopia-correcting intraocular lens landscape, from preoperative diagnostics and surgical planning to patient communication and financial considerations. Thank you for joining the third episode in our podcast series, Mapping the Surgical Journey. I'm joined by our expert guest, Dr. Caroline Watson, and she's also a cataract refractive surgeon, fellowship trained, and cornea specialist. Welcome, Caroline.
Thank you. Thanks for having me.
As we've discussed in the other podcasts, presbyopic intraocular lens are underutilized. And the problem is it's not just the technology that the doctors are having trouble with, but it's also how to select the right candidates. So as you and I know, we've been to many conferences, spoken to many conferences, but there's so much different diagnostic variability. There's so many options out there. We really need to find a way to identify the correct patients and match them to the correct technology. So in this episode, we're going to discuss, your thoughts on the best way to do this. Just to get started on our first topic, and which we're going to title the stepwise workflow, how do we identify the most important steps in the process, and how do we really summarize this for our audience? So in other words, what should be happening in the patient evaluation stage for someone who might be a candidate for an advanced technology or presbyopic correcting IOL? What are your thoughts?
Well, I agree. This is a very important thing to discuss. It's kind of a mystery in our field. Why is there such low adoption of these amazing lenses that give a lot of spectacle independence and, in my opinion, are the best option if the patient's a good candidate. So in my office, we do a lot of diagnostics for every patient. I'm always doing a topography, tomography. I'm doing an OCT MAC. I'm doing multiple measurements of biometry, so I probably have 2 to 4 sets of biometry as well, just so I can see that there is some variation between the testing. And I do some extra things like OPD and epithelial mapping. Just really depends on the patient, but I always like to have as many data points that I can have so that I make the best decision for that particular patient. So all of that's pretty consistent across the board. Everyone gets all of those. And then when I get into the room, that's really kind of where I do my information gathering. I'm analyzing this patient from the second they hit the door. My front desk is kind of picking up on, their personality. They're kind of giving some feedback through the text. Like my texts are spending time with them. I have one technician that goes with the patient through the entire workup process. And even sometimes that technician is able to scribe for me. So it really is a more streamlined way to make sure that there's not so many or too many different people dealing with one patient. And I think it's actually better for the patient, and they feel a little bit more relaxed that they're dealing with one person through that whole process.
I think that's great. So I love how you summarize that there's multiple different technologies, and I agree with you. I always start off with topography or tomography if you have it. I also use the OPD, and I also love the Pedicam, and then OCT macula. I think that's critical, like you mentioned. We have to make sure that the retina is pristine, and it's easy to miss that. One thing that's really interesting is that although you and I think alike, it's impressive that there's still statistics out there showing that fewer than half of the surgeons routinely use corneal topography, and fewer than 35% of surgeons are also using lifestyle questionnaires. Now, I know on my perspective, I don't use a lifestyle questionnaire, but I'm like you, where I speak to the patient and really gather a history. But certainly a lifestyle questionnaire is important. So I think what you've summarized beautifully is that, the workflow is not just measuring the eye, it is using all this information to consistently support the right decision that we have for the patient. And again, it's not just based upon technology, but also getting to know our patients and speaking about our patients, which we'll talk more about in the next podcast as a teaser.
Yeah. Um, well, those are really interesting statistics. For me, that's pretty standard measurements that we get prior to surgery. That's a really easy way to, I guess, get comfortable speaking to the patient about really optimizing their vision when they have that one opportunity, that one surgery. As far as the OCT MAC, I can't even tell you how many times I've caught macular pathology that's extremely subtle on exam at the slit lamp, and it's definitely made me pivot with my decision making. And so at this point, it's more of a covering your butt. You want to make sure you don't um, recommend advanced technology lens on someone who has a pseudo hole or may have a little CME that you can't see, or maybe has like a vitreomacular traction happening. So those are things that we pick up on all the time, and it's so frequent that it's almost it should be required if you're going to do any type of cataract surgery anyway, even if it's basic cataract surgery, because you want to be able to say, hey, look, this was there before your surgery. This did not happen because of your surgery. And so that's another, I guess, reasoning for that.
Yeah, no, very good points. And even going back to the topography, catching those patients with keratoconus or
Yeah,
with regional degeneration. So you're right, not only finding the right candidates, but also avoiding placing a lens that may be inappropriate for certain patients. So
totally. Yeah.
excellent, excellent point. So, well, let's move on to our next topic. So, now that you've collected all these wonderful diagnostics, what should the surgical planning look like, especially in regards to the IOL power calculation? As we know, you can have wonderful preoperative testing, but we still need to calculate the correct power at the end of the day. And some formulas are better than others. How are you deciding this, Caroline? How do you pick?
Um, I really do rely on our biometers pretty heavily. I use Barrett 2 and I use Barrett True K most of the time. So I'm not really manually calculating or checking that just repeatedly, because I think our diagnostics now and our algorithms and, lens normograms are really solid. I think it gets tricky when you start diving into RK patients, post-myopic LASIK, post-hyperopic LASIK patients, keratoconus patients. I mean, you have to be really careful about the, very, very, myopic eyes, very hyperopic eyes. Those are where you have to maybe veer a little bit. But um, for the most part, I'm just kind of trusting my biometry, and it seems to work really well. So I'm not doing really anything extra in that regard. As far as my normogram for like a femtosecond laser paired arcuate system, everybody has their own little way of doing it. So I use the normogram from my fellowship, seems to work, seems to be transferable between femtosecond laser platforms. So I'm getting pretty consistent results compared to when I was in training. And those are things that those laser companies can share with you and can help you with if someone's not experienced using that.
Yeah, and I think those are excellent points. I mean, I love your point about when there's an eye that's not maybe an average length, whether it's extra long, extra short, or maybe they have a corneal condition like keratoconus, that there are these special formulas that we can use. There's a lot of now AI-driven formulas, like the Kane formulas using that's, but I agree with you. I'm using the Barrett Universal formula, which luckily is on my biometry currently. So, I think that's, been shown to be probably the best universal formula for average eyes and even some non-average eyes. But I think, every once in a while I'll still look at other formulas in case just to compare, but I really do trust the Barrett. And of course, for like a post LASIK eye, using the Barrett True K has also been really popular. But if you're not fortunate enough to have these formulas built into your biometry, one thing I always like to make note, and this happened to me before I had the funds to buy one of the newer biometers. They do have the formulas for free on a lot of the websites like ASCRS or APACRS. So that's just something in case someone, when I started my practice, I had to get the
Yeah.
non-formula ones. So there are options, but I think just keeping up to, and we're really lucky nowadays that so many really smart, generous surgeons have figured out these formulas
Yes.
help us, right? Because that's what we do.
Yes,
So yeah,
I
so
agree.
that's a really good point, and just collecting the data is super important, and I think, and you're right, it is about formulas, it's about diagnostic testing, but ultimately at the end of the day, it's we have to integrate all of the data from our diagnostics, and that can be a little tricky too, right? How many times have we had topography, maybe different topographers, right? And then your biometer, your keratometer, they're all showing different axes for the astigmatism, right? So that's always something that can be a challenge. And managing dry eye is so important too, along those lines, which I know you already know lots about, but I always
I'm
like to
glad
hear.
you said that. It's a nice segue into my next comment because, I think one thing that may be significantly overlooked, even in this day and time of all of this ocular surface attention that is in our field, we still aren't being diligent enough at optimizing the ocular surface, treating the ocular surface ahead of time rather than being reactive. I'm extremely proactive. I was fortunate to train under someone who was very experienced with ocular surface disease. And so I learned a lot from him. And I've really used that immensely in my practice. And I do think that it prevents from refractive errors, especially with astigmatism correction and even with, spherical correction as well, especially in post-refractive eyes. You have to be so diligent because they do have a level of ocular surface disease, NK, who knows, that can contribute to inaccurate measurements like you were referring to, different modalities giving you different results. Um, and so I really, really treat every patient the same, regardless of what lens technology they're going to get, because you want to make their eyes healthier uh, as you move them along the surgical process. And if you're working with a referral partner, you want to send them back looking better, seeing better, singing your praises, and them knowing that you took really good care of them, and you were looking at the entire picture, not just, I'm going to do cataract surgery on you.
No, absolutely. It's a very comprehensive consultation and journey. Well, that's actually also a perfect segue to really our third topic. And that is, walk us through, Dr. Watson, like how, on a higher level, we have a nice flow diagram to show our listeners. But how can you walk us through from start to finish, sort of when a patient's coming in? Tell me about, what you're assessing, and the tests that you're doing, and also kind of like matching the patient goals. Now, I know it's a lot to do in just a few minutes, but if you could like a high level overview, kind of almost like a summary maybe of what we've really been discussing.
Yeah, I think this is where people get tripped up a little bit is, okay, how do you know which lens is going to go well with this person? And so you always just want to think top down instead of thinking bottom up, where you're like, everyone's a candidate for a monofocal, and then I'm going to try to find someone who's a candidate for, an EDOF or a monofocal plus or a toric or a multifocal or an LAL. You think top bottom. So I'm just going into that room thinking, is this person a candidate for an advanced technology lens? And then maybe there's reasons that they're not. So let's just pick one. I'm going to start with a multifocal since that seems to be the most, scary thing for everyone. But I just go in the room saying, okay, well, if everything is beautiful, if your testing looks great, I can set expectations for you that are reasonable and you're accepting of that. then I've got great lenses to put in you and you're going to see amazing. So it's like I trust in the technology. I know it's going to work. I know the cornea is going to look great. If the macula looks good, there's no other pathology, I'm going straight for the multifocal. Now, something that's going to make me pause or shift is anything weird, moderate glaucoma. Anything past really like moderate glaucoma is going to make me stop. Our newer lens technology doesn't have as much contrast sensitivity issues as prior versions did. So the contrast loss is not as significant as it used to be, which is why people avoided, premium lenses in these patients. But any macular pathology, any significant diabetic issues, any really bad comorbidities, like they've had strokes and heart, they're just, what I mean? Like they're just not good candidates for these lenses. You don't want to do that. I think people who are very, 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 very particular. So I live in an area that is full of engineers. It's got like the highest per capita number of engineers of any city. And people are like, oh, engineers don't put premium lenses in them, but I do it all the time. And most of them are great, but you've got these outliers, right? You just have to be very careful. So I would start off with, does the cornea look good? Do they have any lid margin disease? Can you fix it? Are they motivated? Do they want to be out of glasses? Do they value what you're trying to offer them? Does the rest of their eye look pretty dang good? We could talk a whole day about the patient selection. That's the hardest part. But I think for the most part, if your eye's healthy, you set expectations, you tell them there's not a single technology in existence that's going to be 100% spectacle free. You will get away with 90% of your day not putting anything on your face. You're going to need readers for, dim lighting and teeny tiny print, but you should be able to see great beyond that. So it's really about making sure they understand, hey, this is a one and done. You never have to have cataract surgery ever again. Do the math. How much does it cost when you purchase a pair of glasses every 2 to 3 years? What if your dog eats your glasses? It's another $800 out of your pocket. So if they do the math, and then to add an extra layer, it's kind of a safety issue. Depth perception with monofocal lenses is not as good as it is with EDOFs and multifocals. So you've got elderly aging population. They don't want to miss a step. They don't want to miss a curb. They don't want to fall. You really need to kind of educate them about why you want your vision to be as good as possible. And I would say most people really are very passionate and they do want it. So if you're not offering it, they don't know it's available. And you have to educate them and make sure they understand the value add.
Well, thank you, Caroline. I think that your summary of the flow diagram was excellent. It's important that in our clinics and in our practice, we have a set pattern or pathway to properly assess the patients, examine the patients, and also counsel the patients. And I think many surgeons do find having a stepwise approach is helpful. And again, thank you for speaking to us also about the diagnostics that you employ, the formulas that you employ, and also the types of counseling that you give to your patients and identifying what's important to them. I'd like to thank all of our audience for your attention and Dr. Watson for being part of this.
Thank you.
We're also looking forward to you joining us for the next episode, Navigating the Conversation, Setting Expectations for Presbyopic-Correcting IOLs. You can explore all episodes in this series, along with additional activities in the full CME accredited program. If you're listening outside the program website, the link is in the show notes.